Because it's not widely available and a lot of people don't use it, but what I do is I'm going to go through it as a more practical sessions to go through cases, how MRI can be used in an acute stroke setting. I'll have much less evidence, but much more practical cases. Now, how do I change? I change this, do I, or change slides? Is that? Excellent. So first 10 to 15 slides will be on the basics of MRI. I know most of you would know about MRI. I'd just like to run through the different sequences. Compared to CT, MRI has a lot more sequences that you can deal with. But more importantly, they do actually give you different information. So these are the usual sequences when you get a MRI scan. So firstly, DWI. Most of you would know DWI equals to kind of acute infarction. But all it actually means is abnormal water molecule movement. So anything that affects tissue molecule movement can look bright on DWI, such as hemorrhage, tumor, demyelination, infection. They can all look bright on DWI. I'll talk to you about T2 showing through a bit later. What I'm trying to get you to think about is the use of it, but the pitfalls of these sequences. So you also hear about ADC, apparent diffusion coefficient. What it does is complement DWI. If you have an acute DWI lesion, the ADC will look dark. But the problem about ADC is that how much dark is dark. Sometimes it's really hard to see a very dark lesion or mildly dark lesion. So there is another component called exponential ADC, which makes a dark ADC looks bright. So what it means is that in an acute stroke situation, DWI will look bright but dark on ADC, but also bright on exponential ADC, which is reverse, make it easier to look. Why is this important? Because in an old lesion, ADC will be normal. So let me demonstrate this. So this is DWI and ADC with time. On the top, you can see the DWI changes with time, with 6 hours, up to about 30 hours become really bright. But about 5 days start to reduce, and about 3 months it became dark. On the other hand, on the ADC, in an acute situation, you can see it's actually darker, but by about day 5, it starts to pseudo-normalize, becoming sort of normalizing, and about 3 months, it actually looks bright. So if you look at the 3 months picture, you know this is an old lesion. So now I put exponential ADC into it. So the DWI looks bright, and then the ADC looks dark. This is acute infarct. The exponential ADC actually looks bright too. So it helps you to actually recognize this DWI lesion is acute. Because if you look at the ADC, it sometimes can be hard to see a dark lesion within a dark scan. And obviously the flare, you can see the changes on T2 shown on the flare as a sort of swollen gyrus. So now I'm going to put all these sequences together. So this is the same patient with acute DWI bright and dark ADC. Then in the same patients, you can see in a chronic setting, this is 3 months later, the DWI becomes sort of darkish, ADC bright now, T2 is bright because it's infarcted, and because T1 shows structural lesion, you can see a dark T1 abnormalities. Flare is a combination of T1 and T2, basically looking at T2 with the dark tissue of T1. So you can see the infarct there. The SWL, which I will talk a bit more about, actually shows a bit of a particular hemorrhagic transformation within the area. So that's what I spoke about, flare, T1 and T2. But more importantly, in the same patient, if you look carefully, if you look at the DWI sequence, it actually looks a bit bright in some area. Without the other sequences, you would think, wow, that's maybe an early ischemic stroke. But actually the same area looks bright on ADC, but also bright on T2. So this brightness in DWI is due to what we'll call a T2 shine through. It's basically a false elevation or false brightness on DWI. You've got to look at every sequences. So briefly on SWI, I'll give you examples later. In the older days, we used GRE, gradient echo sequence, or T2 star, but SWI is a lot more sensitive, which I will show you. Basically, you're looking for iron. Anything that's got iron depositions, it will cause a change in magnetic field, hence the signal changes. So it's not just blood. So hemorrhages can be cerebral hemorrhage, microhemorrhage, subarachnoid, AVM, and amyloid angiopathy. It doesn't really tell you is it old or new blood. However, there are different sequences you can do, which I may not get talking to today because it gets a bit complicated. But it's very useful if you've got a CT scan with a bright calcified dot. You want to see if that's actually, in fact, calcium or blood. The SWI or GRE will help you. So this is a very classical microhemorrhage with amyloid angiopathy. As you can see on the SWI, there are multiple microhemorrhages with subarachnoid hemorrhages. On the right here, you can see the 4 slices. You can see the black color within the middle, which is the blood. And then, is that a pointer? Can I use a pointer? There's no pointer here. There's not. So if you can see within the picture C, there's brightness and darkness. By using that what I call MIP sequence, you can actually tell old or new blood, but that's a bit more complicated. But in fact, in D, you can actually say, see, this patient also has subarachnoid blood too. So we talked about just using non-contrast CT. SWI will help you not just be able to pick up the microhemorrhage, but actually help you sometimes to actually find the blood. You look at the picture A, this has got a motion artifact. The patient moved a bit, so it looked a bit fuzzy. You can vaguely see some blood, subarachnoid blood here. But if you do it on the same patient, a SWI, you can see the blood so much better, and you also come to a diagnosis that this gentleman has subarachnoid because likely of amyloid angiopathy, given all these microhemorrhages. And that's how SWI can help. And the next is MRI, vessel imaging by MRI scan. So most of the time we use what we call time of flight. Time of flight means that you don't need contrast. However, it does have a shortcoming compared to contrast MRI. It's more prone to artifacts. I'll show you in this sequence. On the left, you can see the CT angiogram quite nicely, showing the MCA and the PCA. In the middle, it's a time-of-flight, non-contrast MRA. This looks pretty good, but you can see the white arrow showing the artifacts. Particularly in the bottom, you can see stripes of horizontal lines. This is actually artifact. Then you actually compare to the far right, which is the contrast MRA, it looks so much better. However, because you need contrast and delay time, majority of the time we use time of flight, which is non-contrast. But need to be aware, what you see on time of flight may not be all abnormal, may not be all real. So, the last bit is CT perfusion, MR perfusion. Why do we need MR perfusion? Because we want to see the penumbra. The penumbra of the perfusion mismatch is the area we want to save. MR perfusion also helps you to identify the core or the infarct area, which is red here. What you want to save is a light blue area, the penumbra, and that's why you do perfusion imaging. So this is a patient using MR perfusion up to 14 hours, 72-year-old from the stroke onset. As you could see, there was a bit of old time, we used a more relaxed Tmax value of 2. You can see a large perfusion deficit. As you can see in the middle, there is a perfusion diffusion mismatch of a large area. This patient did not get thrombolysis because it's 14 hours, and 3 months later, you can see the flare, the infarct, completely taking up the penumbra. What you try to save is the penumbral mismatch. So the pitfalls of MRI, as I mentioned, is motion artifacts, the DWI issues, and MRI overcall. The motion artifact is if the patient doesn't stay still, that's what you get. And that's why MRI may not be that applicable in acute stroke situation, where the patient may be confused, dysphasic, and they don't stay still in the scanner, and that's what you get. There are multiple software that can actually do motion artifact correction, but still the picture does not look well. You can see the A got a motion artifact, B is after motion artifacts correction. It looks a lot better, but still a little bit fuzzy. The next is artifact. There are lots of little things on the MRI scan that may not be real. If you look at the middle segment, you can see the big black area. That is simply because the patient has metal on the upper part of the jaw and causing this massive change and affected the quality of your scan. And thirdly, what you see may not be all real. So on the MRI, particularly DWI sequence, you can have a lot of bright areas that may not be real. So in the A picture, the pointer little anterior lesions is actually artifacts. It's not real. But on the other hand, the one on the right is actually real. So you've got to look at the picture with the clinical scenario. So therefore, you know that lesion actually matches what you see in front of you in the patient. So now I've gone through the basic sequences of MRI, so I'm going to try to apply this in acute stroke setting to see how they fit in and how they can become useful. Firstly, MRI to me, the most important thing is helping me to make diagnosis. I do sometimes from time to time do what I call hot DWI, meaning that I've done the whole CT sequence, or just sometimes I've got a non-contrast CT. I need to know, is this a functional patient or is it a migraine? I do an acute DWI to look for ischemic changes. I will show you some of this. So a lot of you do non-contrast CT. You've got a patient in front of you with a non-contrast CT, 45, with a bit of a psychiatric history, you think, well, maybe functional. I'm not so sure this is real. On a CT, you can't see anything. But you do a hot DWI, you put in the scanner straight away. A DWI sequence takes 60 seconds. A DWI sequence takes 60 seconds. With a T2, 3 minutes. So that's a very rapid scan you can do. And quickly, suddenly, you got the diagnosis. This patient is real, has got an ischemic lesion. So that's why it's useful. Now, sometimes very earlier on, they can be very, very subtle and small. So this is a patient, again, you think you've got a right arm tingling, the patient got history of migraine, history of psychiatric illness. You put in a scanner, you suddenly found there is a thalamic infarct, and that actually solves your question. But more importantly, the initial one is actually very faint. With time, that actually gets better. So therefore, you've got to put a time factor in it. When you do the scan very early, you've got to look a lot harder. So again, this is another situation. The patient was diagnosed to be a TIA. In fact, you're doing a scanner, there is a lesion. 30% of TIA has got a DWI lesion. They're not true TIAs. They've got tissue infarcts. So this is another example what we'll talk about. However, when you put patient into the scanner, to the DWI, you see bright things, but not everything bright is true. So this situation, where you've got an elderly patient with lots of risk factors and white matter ischemia, the white matter can actually look bright. If you look at slide A, you can see very bright DWI changes. But the ADC tells you this is old, because the ADC is bright. And in fact, that corresponds very well with the white matter ischemia on the Flair sequence, which is D. So you know that brightness in DWI is fake. However, this is another patient. You can see the patient got a right-sided weakness. You look at the Flair sequence. Yes, there is a lot of white matter ischemia. But within that white matter is hidden behind that, it's acute DWI lesion. So this person has an acute stroke on top of the old white matter ischemia. So that's why the DWI and the Flair have to be looked at the same time. So beyond just diagnosing acute ischemia, MRI perfusion can now help you to select the right patient for therapy. One of the new concepts has been used is what we call DWI Flair Mismatch, which is different to DWI PWI perfusion mismatch. The concept of DWI Flair mismatch is that flare is equal to infarction. So it runs on the principle that flare equal infarction, and the DWI is not all infarcted, which is a bit against what we actually believe. So therefore, this principle based on you believe that DWI will disappear with treatment. So for example, you look at the column A, the first two cases. The DWI is a small dot, and the flare, you could not see a corresponding flare sequence. So there is a DWI flare mismatch. The bottom one, in A column, there is a big DWI mismatch, a DWI lesion on the right, but no corresponding on the flare. So it means that this DWI lesion can probably still be salvaged because there is no flare changes. Comparison, on the B column, you can see the DWI small lesion matched with a flare image. So it means that this DWI lesion cannot be saved. On the bottom one, you can see on the left MCA, there is a DWI lesion and a matching flare sequence. Again, this DWI cannot be saved. So it means that the patient in column B would not respond to reperfusion therapy because everything has been infarcted. On the other hand, the patient in column A will probably be saved because there is mismatch. However, what is missing is a big penumbra. So again, I put side to side. We look at ABC. Firstly, on the A, you get a DWI lesion and a matching flare. You say, well, there is no DWI flare mismatch. There's nothing to do, we go home and sleep. But in fact, if you do a perfusion imaging, there's a large perfusion deficit you're actually missing. There's an M1 occlusion there. If you look at patient B, there is a matched DWI and flare. Again, you say, well, nothing to do, we go home. If we do a perfusion, there's a massive perfusion deficit there with a M2. And similarly to C, same patient, another patient, DWI flare matched, but another thing is another large perfusion mismatch. So what DWI flare is missing, you're actually missing a massive penumbra when you don't do perfusion. So, as I mentioned, it's based on the principle of the flare is infarcted, DWI reversible, but it misses the penumbra. The real problem also with DWI flare is, it's how bright is flare that needs to be real or not real. So the inter-observer variation is quite high. You're looking at a Kappa score of 0.46 to 0.65. And with patients with massive amount of chronic white matter ischemia, it's hard to tell what is new flare and what is old flare changes. So there's a lot of variations and very difficult to interpret. So that's why we use perfusion imaging. Epithet, it's an older study. We use MR perfusion for 3 to 6 hours patient's onset. And it shows that if you give TPA, you will change infarct growth using MR perfusion selection. But more recently, it's Diffuse 2. Basically, Diffuse 2 looking at up to 12 hours with perfusion therapy. The bottom line is if you've got perfusion deficit, meaning a mismatch, reperfusion helps. If you do not have a penumbra of perfusion mismatch, does not matter if you reperfuse or not, nothing helps. So what it means is that you must have a perfusion mismatch to benefit from reperfusion therapy. So as I mentioned, even now perfusion can go up to later time window. This is just a retrospective study looking at penumbra actually exists up to 48 hours, and salvage of such can also lead to clinical benefit. So now we're moving on from perfusion imaging. The MR can also show collateral circulations, but using ASL. It's nowhere near as good as CT. CT is much better for collateral circulations. But using pulse ASL, you can see perfusion of collateral circulations. So look at the patient up the top got good collateral and the bottom got poor collateral. As you can see, the top one, you've got a small DWI lesion, a large perfusion deficit. On the pulse ASL, you can see bright signal changes of the collateral circulation. These patients actually got a good collateral, and hence the large mismatch of DWI and perfusion. On the bottom one, where there is a poor collateral, you can see a large DWI and a matching perfusion deficit because this patient has very poor collateral. As you can see from the ASL image, there is no bright collateral images. So by using ASL and perfusion in MRI, you can still pick up collateral circulations. So I'll give you some other cases when I use all these sequences together. 21-year-old with sudden onset of aphasia. You look at the DWI in sequence B, there's nothing there. There's no ischemic changes. But when you do a perfusion, there's a massive perfusion deficit in sequence C. And then you look at the SWI, you can see what we call the brush side, the dilatations of blood vessel on the left side corresponding to the hypoperfusion. In fact, this patient has migraine because the dilatation of the SWI sequences helps you to look at the whole sequence. Plus also, you go back to the MRI, the DWI, there's no ischemia, so this is actually caused by migraine. Next case is a 65-year-old sudden onset of right-sided weakness. You can see on the sequence B DWI, there are changes, but it's not a vascular territory. Then you look at the MRA, there is no vessel occlusion whatsoever to correspond with that DWI changes. And more interestingly, if you look at a perfusion, because increased blood flow in that area. So you've got no occlusion, increased blood flow, strange DWI lesions, which is not vascular territory. This is status epilepticus. So another patient, 85-year-old, with an old infarct in the right posterior, as you can see on the Flair, and the DWI, which is not bright. You can see lack of perfusion over that area when you overlap it. But then later, when you do the perfusion again, you can see this bright red area of hyperperfusion. It's because this person having partial seizure secondary to the old stroke. So perfusion will to help that, and DWI helped you to tell there's no new lesion. So briefly on the hemorrhages, it's most useful in amyloid angiopathy. I'm going to skip that one. This is to show you that the SWI is more sensitive than GRE. You can see a lot more microhemorrhages and subarachnoid hemorrhages compared to the top row of GRE. You can barely see anything on GRE compared to the SWI in the bottom. So in fact, in subarachnoid hemorrhages, the DWI can also look bright too. So you look at DWI and the SWI together. As you can see the middle case, you can see the subarachnoid hemorrhages actually looks bright on DWI. So you've got to make sure you look at all the sequences. And MRI can also help to tell you the etiology of the hemorrhage. You look at the top one, it's basically hypertensive because you can see the SWI on slide D, there's no microhemorrhages. On the other hand, the bottom slide D, you can see all the subarachnoid microhemorrhages. So the top one is due to hypertension, the bottom bleed is more likely due to amyloid angiopathy. So that helps you. But SWI can also show blood vessels clots. There are 3 cases here that actually shows you that SWI can show clots within the corresponding vessels, which could not be seen, particularly in case on the right-hand side of a 72-year-old man. The MRA did not show any vessel occlusion. But if you look at the SWI sequence, you can see a clot in left PCA P2. This is a case where you can also look at MR perfusion, DWI, SWI together. This is the same case about like the brush where you got acute ischemia in slide A on DWI with very little changes in slide B with Flair, but large perfusion deficit in slide C. And you can see in slide F, there is a brushing sign where there is dilatation of collaterals. due to the clot in slide E, when you can see the little clot in the vessel. So with the whole sequence, you can actually tell the story by using MRI. I'll probably skip that one. Lastly, vessel imaging, MRI can actually tell you ulcerated plaque by using contrast, and that will tell you the risk of further event. By using contrast on vessel wall imaging, this is a plaque in the MC on the left. With C, you can just, with the T2 sequence, but pre-contrast D compared to post-contrast E, you can see there is increased contrast in the plaque of the vessel, suggesting this is an unstable ulcerated plaque. So lastly, a few more examples. MRI can show you Moya Disease, Reversible Fatal spasm, which tells you the cause of the headache and the neurological deficit, and also tell you sagittal sinus thrombosis. Sagittal sinus thrombosis should be suspected if you've got lesions outside of your vascular territory, as in this case. You can see the sinus thrombosis in slide C with the corresponding DWI. Probably skip that. Lastly, there's a new MR venous imaging where you can see the venous flow on slide B compared to DSA on slide A. What it can show you, the venous imaging, is show you the grading of the collateral circulation, hence prognosis and outcome. So other mimics, this is a case of 56-year-old gentleman who came with confusion, speech disturbance. As you can see in slide A, there is bilateral changes and doesn't conform to a vascular territory. There's leptomeningeal enhancement, and so this is herpeencephalitis. Not everything is stroke, and MRI can tell you this. Other differential, Cardisil, MELAS, and SMART syndrome. Basically, these are patients who have received radiotherapy to the brain and have migraines and recurrent neurological symptoms, and this is a classical pattern that you only pick up by MRI scan. So one case to finish off. The 85-year-old gentleman went to bed, woke up in the middle of the night, locked in. She was fully awake and he could hear his wife walking around the room cooking breakfast, but he could not move, could not call up to the wife. Then the wife tried to wake him up, but he was non-responsive and drooling of saliva. The ambulance arrived, intubated him. By the time he came to our hospital, he was also intubated. Well, by the time we saw him, it was 17 hours from the stroke onset. So there's the clot in the basilar. We did a hot DWI, and DWI shows there was a significant amount of tissue that can be saved, and there was a large 2-centimeter clot in the basilar. And we did a clot retrieval. The patient went home in 2 days fully recovered, despite it was 17 hours. The moral of the story here is, without the MRI scan, I wouldn't know how much of his brainstem is still functioning. By knowing that, we were able to go in and salvage him. So in summary, MRI is extremely useful for both acute and chronic situation. The DWI is very good for acute stroke identification. The SWI is particularly good for looking at bleeding and high risk of bleeding. MRI can provide information on the cause of the problem, such as hypertension versus amyloid. Perfusion scan is really important for selection of patient for therapy, and MRI can also identify stroke mimics. Thank you.